Nothing about us without us. The role of people with diabetes in research. Krista Lamb is the communications lead for Diabetes Action Canada. She is a writer, communications professional, and podcast host. Krista is the producer and host of multiple podcasts, including the Actions on Diabetes podcast with Diabetes Action Canada. Her first book, Beyond Banting, From Insulin to Islet Transplants, Decoding Canada's Diabetes Research Superstars, is available now. Dr. Holly Witteman has lived with type 1 diabetes since age 7. In her work as an associate professor in the Department of Family and Emergency Medicine at Laval University, she studies how best to adapt technology to people rather than expecting people to adapt to technology. She lives in Quebec City, which is unceded traditional territory of the Huron-Wendat. Dr. Joyce Dogba is an associate professor in the Department of Family and Emergency Medicine at Laval University. Her research looks into the involvement of people from ethnocultural minorities in patient-oriented research. She is a co-lead on patient engagement within the Strategic Patient-Oriented Research Network in diabetes and related complications. Dr. Joseph Cafazzo is the inaugural Wolfond Chair in Digital Health and Lead at eHealth Innovation at the University Health Network. As a biomedical engineer, Joe observes healthcare delivery from the inside out and works on ways to keep people out of the hospital by creating technologies that allow for self-care at home.
I'm really excited to be talking to our panelists today about this important topic. And so I'm going to start right off because I know we have a really short session today and 3 amazing people to talk to. So Holly, let's start with you and your work. I really wanted to know a little bit more about how people living with diabetes can be involved in the research process from the very beginning. I know that's something you've worked on a lot, and I don't think people understand that even at the inception of a research project, that people living with diabetes can be at the heart of that.
Yeah, thanks. That's a great question. So I think there's more and more recognition of this, that if you do research without involving people, the people who should be served by that research, then the research itself isn't necessarily going to serve people in the way it should. And so people living with diabetes can be involved in diabetes research right from the start, which happens in developing research questions. So this is the question: what are you going to study? What questions are you going to seek to answer in your research? And then people can be involved all the way through, from developing the research question through to helping to develop grant applications and submitting grant applications. I think for a lot of people who haven't been involved in that process before, sometimes that's where you're like, oh, wow, this takes a really long time. It takes a long time to write them, and then you have to wait, and then you get news back and you have to reapply. And then once you actually have funding to do research, then people can be involved across every aspect of it, including, so we have projects where we have mixed teams of researchers, health professionals, people from decision-making organizations, people from diabetes organizations, and then a lot of people living with diabetes who bring their lived experience to the table every time we meet and we talk about what we're going to do in this project, what our goals are, and how we're going to get there.
That's really amazing. And I think it speaks to the fact that having people from the very beginning is so critical. And so on the next stage of the research, can you tell us a little bit about how people living with diabetes are actually involved in the process, or give me some examples of that?
Sure. So for example, one of the projects that I'm most involved in has to do with developing research questions for epidemiological research. So people have heard about epidemiology a lot recently because of COVID. I know my colleagues who are epidemiologists used to get the people asking them, oh, so you study skin diseases? So epidemiology is the study of diseases, basically, and how what causes diseases, what is associated with them, what are the things that we can do to prevent diseases that are preventable, what are the things that we can do to treat diseases. So one of the things that happens is people will analyze big databases, and they will come out, and this is where you see things in the news like, drinking coffee is associated with this really good thing. And then the next day, drinking coffee is associated with this bad thing. And those are epidemiological cohort studies. And one of the questions that we had was, well, a lot of these analyses are based on what researchers think is important, but what do people with diabetes think is important? And so we put together this project where we have committees of people living with type 1 diabetes or type 2 diabetes, and they are developing the research questions themselves. So we worked with them to sort of talk about, okay, what are the kinds of research questions that you can answer with these kinds of data? And then they went off and did all the work to develop these big, long lists of research questions that we are now working with to sort of translate them and figure out, okay, which ones are we going to be able to answer? And then we go back to them and they decide, okay, which ones are the most important to do first.
Wonderful. That sounds like such a fantastic project. And I think it sort of brings to mind another project I heard about, which is the do's and don'ts that people living with diabetes created actually to provide to healthcare providers and other people working in research who are often asking them to work in research projects, but not necessarily knowing how to do that well. Can you talk a little bit about that?
Sure. So the Do's and Don'ts Project, this was something that patient partners initiated within our network. So we have a wonderful cohort of patient partners. So we have about 80 people now who are actively participating, who are either on research projects, who participate in discussion circles. Different people have different levels of involvement, and it really depends what they want to do and what's interesting to them. But one of the things that's always challenging is making sure that people are involved in a way that is meaningful to them and in a way that feels good to them. And for some researchers, this comes really naturally and it's really easy for them. And sometimes it's just a really good match between people living with diabetes and the research team. And other times it can be a little bit more of a challenge, especially if the researchers haven't done this before. So this takes some skills and approaches that not everyone has. And everyone involved in Diabetes Action Canada has to go through training on how to do this. So researchers don't necessarily know how to do this. So we require that everyone go through this one-day training. But sometimes one day still isn't enough. And so one of the things that patient partners in Diabetes Action Canada did was got together and put together this really practical, great list of do's and don'ts. So what are things that research teams can do to help make sure that patient partners who are collaborating with them feel included, enjoy the experience, feel that they can contribute the things that they are there to contribute, and that it's a really positive experience for everyone.
Excellent. That sounds so fantastic. And it sort of leads me a little bit into my questions for Joyce. So Joyce, I'm looking really forward to chatting with you about some of your work that you are doing around barriers and enablers to people with diabetes getting the healthcare that they need. And so I wanted to ask you a little bit about what your work is, in particular with marginalized communities, because I think that's something that's very important.
Yeah, thank you very much. And I'm very pleased to talk about this project. And as you have learned about it, this is a project that aims to dig into what are the barriers and the enablers of people from the ethnocultural minority in getting screened for diabetes retinopathy. So people will say, but why do you want to know those barriers? Every barrier is common for everybody, but I'm happy to say that this research have shown that not all barriers are similar to every people. So what we did with the team in Ottawa is that we target, because of limited resources, we target 3 communities. So people from Pakistan, people from China speaking Mandarin, and people from speaking French, either from African descent or the Caribbean. Why did we focus on this? It's just a matter of being practical, because we wanted to interview them in their mother language, except for the French one. So it was difficult to have limited resources. And what did we do? So we used a framework that is well known to go and look and classify why are people reluctant to come for this screening. So we went about interviewing people, and we had a total of 39 people that we interview. So these are immigrants to Canada, as I said, from these three communities. And the interview were done in their languages. So one in Mandarin, one in Urdu, that is a language from Pakistan, and the other one in French, because it was very, the heterogeneity of people from Africa, we just use French, and this can be a limit to the study. And what did we find? We find that there are common barriers as everybody, for example, the difficulty in getting the appointment, the delays in getting back, getting to the hospital. But there were specific barriers. For example, you will be surprised to see that people told us that winter is in itself a barrier, and people also question the trust that they have to have in their medical doctor, because this person has not been trained in their culture. So how is this person how can they trust these people? So you will see that there were some specific barriers, and we can also mention some barriers of people who found it very weird, very not acceptable to have the professional so close to your mouth, because this is not acceptable in their society. So these are not anecdotes, these are things that happen. And you will see people, especially from China, who told us that every year they have to go back to their country to get their health checked in their native language to know that they are well. So these are some results that we came across in this study.
And this is really fantastic, because I think, one, it brings to mind some of the things that we really don't think about in terms of the barriers to care for people living with diabetes or at risk for diabetes. But the other thing that it really strikes me is that in looking at the work that Holly talked about with involving people living with diabetes in the actual research project, can you tell me a little bit about how you guys did that?
Yes, I just want to say that without patient partners being involved, it will just be impossible for us to carry out this project perfectly. Why? First of all, the question arose from patient partners. They say, why do we continue to assume that barriers are universal? So we took it from there, and say, okay, and they say you cannot disconnect this cultural influence on the habit of seeking care. So that was the first thing. And also, it was for us impossible to reach those communities without patient partners. So we have 2 patient partners from each group, 2 from Pakistan, 2 from China, and 2 African. And they helped us, first of all, to understand that we can just go into the community and expect people to welcome us as researchers. So they explained to us that usually people will identify to the researchers. So the fact that they were in the research team, so it paves the way for people of their community to see them not as suspicious, coming to dig into some things, but we were welcome because of that. And especially for the Pakistan community, we were very, very late in recruiting patients. It was simply, at a certain time, we thought of just forgetting about the project. Then we came across these patient partners who just went to the community, speak to the leaders of the community, and within 1 month, we have every patient that now say, okay, we agree to participate. So patients were involved in defining the research question. They revised the interview guide. So after translation, they revise it, and with special questions telling them how, for example, how will it resonate in your community if this question is asked like this rather than like this. So they guide us in that one, and they also prepare us to know that, okay, when you are going to interview, for example, women, you need to go there with a woman as a researcher, and you need to get prepared either to go into the mosque or just to put a veil. So we were guided in the whole process, and after we were these patient partners help us in interpreting the results and even drafted the article and gave us feedback. So they were involved throughout the research project. Yeah.
That is so important. And I think it really, something you said is going to lead me into my question to Joe, which is about that you had to build trust in the community. And Joe, I wanted to talk to you about the Connected project. And one of the things that I know was central to that was getting involvement from the type 1 diabetes community and making sure that they trusted the process and were interested in being involved. So can you tell me a little bit about that?
Yeah, so it started off with an idea from Diabetes Action Canada that Canada really needed its own diabetes registry. And what a registry is just a way of people living with diabetes to volunteer their time and register in the platform so that they can be later recruited into clinical trials. And I mean, the US has a very prominent registry. Some of the Scandinavian countries have a great registry, but Canada doesn't. And look, we've benefited from the research of other countries, but there are times where research in Canada on people living with diabetes is very important, especially when we're making decisions on reimbursing for CGM and all the, what makes Canada unique, its Indigenous populations and so on. So the need was there, and we presented this at a workshop with the T1D think tank initially, and they were very polite about it, but they were very underwhelmed about the idea that we had. And so we realized that we needed to regroup and create something that, even more so than just having a say, where we really want to get is that the community owns this platform. Not only understanding the research that's going to be facilitated in it, but maybe having an opinion on the quality of the research or why it's important to them. And hopefully that they can encourage research that is more aligned with their values and their needs, and also to create a better experience for doing research in Canada, because the research experience of people living with diabetes can be quite uneven in the sense that some organizations are really good and treat the participants well, and in others it's not. And we really want to modernize the infrastructure, because a lot of diabetes research is done like you're just being asked when you come to clinic, or you're walking down the hallway at the hospital and you see a flyer, and it doesn't really reach a lot of people who aren't associated with an academic center like the Hospital for Sick Kids or Toronto General or McGill or what have you. And how do we reach those people who don't ever get asked? Because if we're relying on people who just come to urban areas, we know that it's going to skew and not be very representative of everybody. So over the last couple of years, and this is mostly the work of my colleague, Shivani Goyal, she did a great job in engaging really hundreds of people in the discussion. And the first version of Connected came out on January 21st, and it is a work in progress. But we really hope that the community can rally around it and truly own the platform and its future direction.
Wonderful. And for those who are watching us right now, if you do live with type 1 or are a caregiver for someone with type 1, you can go to connected.ca. That's connectt1d.ca in order to find out more. I just wanted to make sure that info was there in case there's anybody who was interested. And so I want to thank all three of you for letting us talk to you a little bit about involving people living with diabetes in the research process. I think the whole ethos of nothing about us without us is really important. And I think that's going to be really pivotal to the next iteration of diabetes research in the next 100 years. So thank you, everyone, for joining us.
Thank you, Holly, Joyce, and Joe. We're now moving to the live question and answer period. So we have a question right here. For research teams that want to start involving people living with diabetes in designing research, where should they start beyond the do's and don'ts? Is there a roadmap or a framework that can be followed, or does each research project, or does each project need their own?
I can't see Joyce. I can't see her thing, so I don't know whether to toss it to her. But maybe I'll just say, if you're in Canada and you want to do this, you should Diabetes Action Canada. That's our job. We will help connect you with patient partners, and we will guide you through. And I'll toss it to Joyce, who has more research expertise about this.
Oh, thank you, Holly. But I think the most easiest answer is just to contact us. But there are steps, First of all, you have to identify patient partners. You have to reach out to them. You have to explain what are your expectations in an understandable language, and you have to sometimes train the researchers and train the patient partners. So we have some protocols to follow, but the first thing is you need to contact and to build trust. And we have experience in that, and we can help you with that one. Thank you very much.
Perfect. Moving on to the next question. What do you think researchers often get wrong when it comes to working with people living with diabetes and trying to incorporate them into projects?
I might try that one. We get a lot wrong. And it is a huge problem in that I think it's often not research that is representative of the community. There's a lot of research that is done that obviously don't include adults or don't include pediatric populations, don't include women, don't include Indigenous populations, don't represent the diversity. And sometimes it gets so bad that our research organization, CIHR, have to insist on having rounds of research that are specifically for Indigenous peoples, or specifically for women, specifically for pediatrics. And so I think that's a big challenge. To me right now, I think a lot of research is done, again, in areas where there is an academic center, and it's always a huge challenge to get people involved who are not engaged, as been said tonight, is maybe you're not thriving and disengaged, but you are representative of part of the community that needs to be part of research, because these are the biggest challenges that we face.
Thank you, Joe. This is a question for Joyce. Are there resources that researchers can look at for ways to effectively do research with people from ethnocultural backgrounds different than their own?
Yeah, there are resources, but not a lot of them. So first one is that in Canada, we have the CIHR, so the Canadian Institute for Health Research, have organized some SPOR units. So these are provincial units that are dedicated to supporting researchers who want to do research involving patients. So first thing is to reach out to those units and get some help. Although these units do exist, we have noticed that there is an underrepresentation of people from ethnocultural minority. But once you point out specifically that you want to target those populations, they can channel your request to some researchers who are doing it already. And this, I just want to mention the fact that Diabetes Action Canada has been championing this, because not only do we have patients from the general population of Canada, but we have from immigrant, so we have ethnocultural minority, we have from First Nation, and so we have been able to integrate all this population, and so we have developed this expertise. As I'm saying, it is not common. It is not, you need to seriously look for people interested, but there are general resources that you can adapt to your cases. But the first thing is that we also need to work with a community organization. So these community organizations are a key that will open the door to ethnocultural minorities. Thank you.
Thank you very much, Joyce. Thank you, Joyce, Holly, and Joe. This actually concludes the live question and answer period. I am now going to turn it over to Jackie James for some closing remarks.